going to go to Q&A. Hopefully we'll get, until I get cut off here, we'll just take them one at a time. So the first one is from Mithun Amit. How will uncertainty in reimbursement affect your strategic planning going forward? One person, I guess, try to answer as briefly as you can.
We are assuming that the genie is not going back in the bottle and that telemedicine reimbursements will continue at something like the current level, which is less than inpatient. But we're right now, strategic plan assumes that that will continue.
Wonderful. Next question from the same individual. How would you differentiate telehealth from telemedicine? Too long of a pause. Let's skip to the next one. Okay, Dr. Melissa Rani, how are you ever concerned of a misdiagnosis with telehealth? It does not work with every field in the healthcare. Example, dentistry.
I think you need to know the limitations of telehealth and understand what you can and can't do via sensor data. So there definitely needs to be a clinical practice around it. Otherwise, you'll get in trouble.
Great. Computers cannot look at the clinical history to help diagnose. They only provide a consistent starting point and remove some judgment. I guess that's just a comment. That was not a question. Let's see. Interest in panelists' thoughts on using technology to prioritize the distribution of the COVID-19 vaccination once it's approved, given the lack of federal policy.
I can take that one. So identifying people to be vaccinated or even tested, frankly, is a huge problem. So when you look at the manufacturing, the distribution of vaccine, and then the administration of vaccine, and then more importantly, actually, what happens after the administration. So how many people develop symptoms? How many of those people have side effects? How many of those people need to be hospitalized? That becomes a technology solution at this scale. And unfortunately, without strong federal leadership, that doesn't exist. Our organization has planned for it. So we're doing that with testing today with very small profile sites around the country. And we'll convert those for vaccination sites as well. So.
Fantastic. Thank you for that. Here's a very specific question. Josh Goldberg. Hi, this is Josh from Klaus's Unified Data Fabric team. Klaus, what is a Unified Data Fabric team?
It's the team that's taking data from 400 clinical systems and a multitude of research sources and building a unification of that in an easily accessible way to anybody who needs data for research.
Wow. So exactly just what we talked about. That's fantastic. I'm curious to hear perspectives. What does everyone anticipate to be the greatest and most significant obstacles to healthcare digital transformation within the next 5 to 10 years?
That one's easy. People.
So people, the consumer, people, the working, the management.
People, the tool makers that have to build better tools, people, the institutions that have to use them, and people on the outside and people regulators. Sorry, Tom.
Yeah, I was going to say we've used the word trust. I don't know how many times tonight. There's not a oversupply of trust. Vaccination rates, we max out at 45% for the flu. Don't think that everybody is going to race. Culturally, we don't race toward vaccinations. We actually have to, but get toward that trust that this is in their best interest. And I think, frankly, the utilization of tools that are not built to make life easier for clinicians and other folks in the clinic or the hospital workflow, that's going to be a category killer, in my opinion.
Cesar, any comments to that, or should we move to the next question?
Well, since we're glorifying data, I would say that with my evidence-based medicine hat on, we should fear bad data. So there's, frankly, there's a robust body of evidence that much of the research many of the publications, and it's thought to be upwards of 40, 50%. Yeah, so those publications include in them studies that cannot be recreated. So they're either falsified or they're poorly performed, and therefore there's bad data in this massive amount of data sets. So every month you have thousands of journal articles that are published. When you put your evidence-based medicine hat on, you realize that the vast majority of the data is useless. And so, how does a data scientist, how does Klaus's team identify the good data from the bad data? It's an incredibly difficult thing to do. And frankly, it's critical to the mission, right? So if you've got a machine learning agent, and we've identified that if you use the wrong platform to teach it, it's going to come out with bad outcomes. Similarly with these types of data integration projects.
Klaus, is that the diagram behind you? Is that the data cleaning system architecture?
It is not. This is actually not my handwriting. Mine is much worse than that. But to Cesar's point, is a really good one.
Okay, we have. I'm sorry. Go ahead, please.
I was going to say you have to accept. You have to manage the life cycle of data, and it starts with where Cesar was, determining what's good data versus bad data.
Somebody had a question for us, and it was one word. ICD-11 ? Or is that a bad word that we don't even talk about?
ICD-10 was hard enough, so I don't know about that.
I mean, that is the problem in healthcare today, right? People's diseases haven't changed in decades, if not centuries, if not millennia. And the administration of healthcare services changes every few years, and it creates this massive burden on all the healthcare leaders, in this virtual room, and all the employees of these health systems. So ICD-11 is a bad word.
Okay, so we have we got the 5-minute warning, so we could probably just take one or two more questions, and then we'll let the president-elect conclude. Anonymous attendee post, based on what I have heard, would you say the best area for telehealth / AI would be as an assistive technology, as not solely to diagnose, treat, etc., as an efficiency tool and process improvement tool?
Based on the way the question is phrased, I'd say yes, but it's an augmentation to the trained professional. I think we all three said it's not at a point where it can stand on its own.
So it's an assistive tool, kind of like Tesla drives, but not fully by itself. Is that a good analogy, would you say?
I think Tesla's ambition is to actually drive the car and just have the human monitor it. I don't think that's where we are yet in healthcare for all reasons.
And that shouldn't be our ambition as well, or should it?
With the current generation of technology, personally, I'm not seeing it because of the limitations in the technology we talked about.
We're not seeing it in the near future, but the ambition
should be there. Technology. When we get explainable AI, maybe, but that's some years out in the future.
Okay. So last question here. Boy, there's still quite a few here. What advice do you have for complex organizations that have multiple and competing streams in virtual care / telehealth space led by smart people? !
Am I allowed to give a quick answer since we're at the end of the session? You have to find a really, really good storyteller. Right? Cesar and Tom both talked about storytelling earlier. You have to find a really good storyteller that can convince everybody to run in the same direction based on the same story.
Leadership, in short.
A certain flavor of leadership. It's all about telling a story that everybody buys into.
Yeah, and also a standard for patient experience. You're not going personally, and no offense to any of my portfolio companies, there's no one platform to rule them all. And then you're going to get slightly different user interfaces. But if you set standards for how you treat patients virtually, then you can have consistency across multiple systems.
I would add on that ego, which writs large in healthcare in this industry, ego is the enemy. And if you can find a leader who's brave enough to tell your doctors that, and oftentimes it has to be another doctor who has some status who can say, look, that's a pet project of yours and it has no place in this organization. It doesn't take us forward in our consumer approach, our patient approach, our outcomes. You have to be an ego killer as a healthcare leader, in my opinion.
Wonderful. I'll just conclude with the fact there's a few shout outs here, people just saying a flurry of thank yous. One person, when you mentioned the importance of quality of information, wrote GIGO, which is a joke in computer science, garbage in, garbage out, right? If you don't have good data. People are saying measurable outcomes, more thank yous. So, and then people saying a greater focus on wellness versus illness, which I think is a point that you guys truly emphasized here in a very digital perspective. So with that, I'll thank our panelists very much. It was a real pleasure having you and hearing your projects and your thoughts and the visions. Good luck to you all, and thank you for pushing hard to transform and make healthcare better for the rest of us. Much appreciated.
Thank you.
Thank you so much.
All right, thank you all. Good evening. My name is Sam Lin. I'm the president-elect for HLNY. We're glad that you have joined us tonight and hope you have found today's program valuable. I want to thank our distinguished panelists and moderator, Tal, Klaus, Tom, and Caesar. You guys did a great job. And if I may, just wanted to share some high-level points that I've heard. You know, care drives technology tools and not technology driving care. Extensibility is important to provide that connected, integrated care to multidisciplinary teams to fill the gaps. And we still have a long way to go with machine learning and AI. Technology can be biased and can actually widen disparities. And I also kind of heard indirectly addressing total cost of care, using that digital front door to not provide unnecessary services. And Tom, I love hearing about the startup about turning clinical language into understandable narratives. Your collective experiences really provide insights on how we can work together to innovate the care delivery model to improve health outcomes. So thank you all for joining us today. And I also would like to acknowledge the support of our sponsors who made this panel discussion possible. I would also like to encourage you all to visit hlny.org for our last program of the year on November 19th, Professional Burnout, Leading Your Organization to Wellness. As Nick mentioned, we are proud to have a keynote speaker, Michael Frisna, an international speaker, author, and faculty for ACHG. I had the honor to speak with Michael, and I know he has a wealth of knowledge on this topic to share with us. And we will also be providing 1.5 face-to-face credit for this event. So I want to thank you all again for joining us tonight and hope to see you at future events. Have a good evening, everybody.